Okay, well, HIV is surprisingly common in the UK. There's about 100,000 people who are HIV positive under care in England, Wales and Scotland, and most of these are now diagnosed. The people we need to worry about, however, are about the 8% of patients who are undiagnosed, who are living with HIV and are unaware of this. It's important to diagnose these people because they could present to care, and if these things are overlooked, then they'll come to harm as a result. The people that are most important to diagnose, however, are those who recently acquired their infection because they're the most infectious. And the way one can recognise HIV seroconversion illnesses is it can present with fever, malaise, arthralgia, sore throat with a rash. Although all these things are not uncommon in themselves, but for them to occur together is unusual. So if anybody who presents with these signs and symptoms, which could easily be mistaken for a glandular fever type illness and whose monospot test is negative, one should always exclude HIV and certainly consider it in one's differential diagnosis. It usually resolves in 2 or 3 weeks, which is a bit longer than one would expect for glandular fever or a flu-like illness. The newer 4th generation HIV combination tests, which detect both antigen and antibody, will detect HIV seroconversion illness, or at least give an equivocal result. So if somebody presents with these symptoms and you do an HIV test, at least think about it. If the results come as equivocal, then you need to get expert help, and the virology department will probably do further testing, including tests for HIV viral load, which will clarify the diagnosis. Earlier tests, 3rd generation assays, and some point of care tests will not necessarily pick up early HIV infection. As we all know, HIV is transmitted sexually through blood and body fluids, and occasionally, very rarely in this country, through mother-to-child transmission. About half of HIV transmissions in the UK occur through men who have sex with men. And in terms of groups that we should consider testing, we should certainly not miss the chance to HIV test anybody who have any men who have sex with other men. But other risk groups include people who come to this country from parts of the world where HIV is more common, and that includes most parts of sub-Saharan Africa. The full list is available on the WHO website. Other people who should be offered an HIV test and strongly encouraged to have one is anybody who presents with any indicated condition that would trigger the thought of HIV in the differential diagnosis. And there's a full list of these in the newly published British HIV Association guidelines on HIV testing. These include obviously anybody with tuberculosis, lymphoma or hepatitis, anyone who presents with the mononucleosis-like illness as I discussed earlier on, anyone with any neurological symptoms, which could include an unexplained space-occupying lesion where one has to exclude toxoplasmosis, or any primary intracerebral lymphoma, all of which could be HIV related. Patients presenting with cryptococcal meningitis can often be overlooked when people don't consider that in their differential diagnosis unless you've ruled out HIV. And any other progressive neurological disease, you need to think about HIV in the differential diagnosis. In terms of dermatology, Kaposi's sarcoma is now fortunately rare in the advent of effective antiretroviral therapy, but patients can occasionally present with severe psoriasis or seborrheic dermatitis, which doesn't appear to respond to conventional treatment, and all these patients should have HIV excluded from the differential diagnosis. In terms of gastroenterology, patients with unexplained diarrhea, unexplained weight loss should have HIV excluded, as well as anybody who has salmonella or Shigella infection, which doesn't have an obvious cause. We've already mentioned lymphoma, but other malignancies that can be associated with HIV include CIN and cervical cancer, anal intraepithelial neoplasia and anal cancers, head and neck cancers which can be related to HPV, as well as HIV, seminoma, and obviously the lymphomas and Castleman's disease, as well as Kaposi's sarcoma. One of the things that is commonly overlooked in patients who present late to care, if you look back in the notes, is many of them have got unexplained blood dyscrasias that have been overlooked. So anyone who has got an unexplained thrombocytopenia, lymphopenia or anemia should automatically have HIV excluded, so that these mistakes aren't made again. So In essence, then, anybody who's presenting to care with one of these unexplained illnesses should routinely have an HIV test. There's no need to do sexual history or do any other form of risk assessment. What we should be doing is performing an HIV test in the same way as we do a full blood count. And this is particularly important in areas of the country where HIV is disproportionately common. And these include London, Brighton, Birmingham, Manchester, Blackpool, Leicester, and also Northamptonshire. And there's a full list available on the British HIV Association guidelines, and the Public Health England also produce a map with hotspots on. And NICE currently recommend that anyone who presents to hospital care and is having blood taken for other reasons in an area where the prevalence exceeds 2 per 1,000 should be having their blood tested automatically for HIV. And areas of extremely high prevalence where the prevalence exceeds 5 per 1,000, even if they're not having blood taken for other reasons, they should have a blood test, or at the very least a point of care test for HIV to exclude HIV, to make sure we don't miss undiagnosed infection in these patients. Other groups that should have routine HIV testing will include any woman who's pregnant, because we've almost eradicated HIV in children in the UK now, since we've been doing antenatal testing since 1999. So clearly we shouldn't miss any more of those. And any woman who's pregnant who may have been subsequently exposed to a new partner who may be positive should have a repeat HIV test later in pregnancy. In conclusion, I'd say that HIV testing should be a normal part of patients' clinical care. We should have no more concerns about doing an HIV test than we do have in doing a full blood count. And in terms of consent, most patients, all you need to do is to tell patients that we routinely do HIV testing in all patients who present to hospital care in line with national guidelines, and no further counselling or process is required. And we've certainly been doing this in Leicester now for a decade on the acute medical admissions unit with no complaints or concerns, and have diagnosed many people who would otherwise have been missed, and as a consequence saved their lives.